So brain injuries are classified as mild, moderate, severe brain injuries, and the variety of things that we see here, trip and fall, minor head injuries, usually fall under the mild category. Patients are usually observed, they get scanned, and after 6 hours, 6 to 24 hours, they're usually released with follow-up. The moderate ones are the ones that need to be admitted and observed overnight, and sometimes may or may not need to have intervention if they have a bleeding in their brain and that sort of thing. The final one is the severe category, and those are the patients that are comatose, unresponsive at the time. They need to be intubated. Those are patients that end up being flown out to a tertiary care center like shock trauma and have extensive neurocritical care. These are the different categories, and mainly is the impact of the head injury and what the clinical presentation is of the patient.
Common symptoms are sometimes headache, sometimes confusion. They might not even have recognized that they had an injury, so they come in and somebody notices that, hey, you don't seem to be yourself today. They might not even recognize that they've changed. But a lot of times it is a headache, seems to be a common theme, or where their speech can be slurred, something's a little bit off. And patients' families will tend to bring them in rather than them seeking help themselves a lot of the time.
It all depends on the type of injury. So if there is, Wendy mentioned headaches, those are typically the minor injuries. And those injuries, typically people get better, and then they sometimes have post-concussive symptoms where, like athletes, for example, get a lot of this. They get a head injury on the field, and they feel fine, and then afterwards they have issues with headaches, trouble with lights, trouble focusing at school, nightmares, that sort of trouble sleeping. So these are the kind of the milder type of injuries, the concussion type injuries. The other ones where there's bleeding, depends on how fast the bleeding is progressing or whether it's progressing at all. If there's slow progression of bleeding, it may start with a headache, and then patient becomes more and more unresponsive. And then that prompts emergent kind of care. People that have, minor bleeding that's stable, usually symptoms resolve over time and they do fine. But almost always there's a headache. Almost always there's trouble focusing, trouble with cognition.
Word finding tends to be a problem.
Exactly.
Word finding tends to be a problem where it's on the tip of their tongue, but they just, and the families or, even themselves will say, something isn't right, because sometimes the trauma is very mild, especially if there's a large collection of either fluid or blood and it starts to move the brain in a certain direction. It can really cause their balance to be off. Or it depends on where in the brain the injury is located.
And that's when you start getting concerned, is when you start to see neurological symptoms, not just the headaches and the generalized symptoms, but you start to have deficits, weakness, numbness, trouble with vision, word finding difficulties, memory issues. These are concerning enough that most of those patients are admitted, observed, rescanned, and a lot of times they require intervention. I think the two patient populations that I get most concerned about locally are the elderly population, where they bang their head against a door or the car, or they just have minor head trauma. They don't make much of it. Usually those are the tougher population of people.
Right.
They think that this is nothing, and then usually their significant other or somebody around them says, they're not acting themselves for the past 24 hours, and they bring him in. And the other category that we see here a lot of is the athletes, the high school, students that end up playing, contact sports, and they come in, and of course those parents are extremely worried, and the athletes are mostly concerned about getting back to sports,
right.
And the parents are the ones that are aggressively trying to make sure that their kids are fine. So these are the two categories that we see here. Typically, the high impact, high energy trauma to the head that requires high ICU care, neurocritical care, usually those patients are flown out. They're recognized on the scene as a major head injury, and they're usually flown out to shock trauma because that's our partner institution. And then they're taken care of there.
Odd to say, sometimes patients will say they have no recollection of any kind of trauma in a certain age group, usually in their 70s to 80s or above, it seems. They might have like a strange shift, like, they just made a quick motion or something, and then they get a little tear of a blood vessel, and then they get a subdural hematoma. And so that, I'm not exactly sure why Joe Lieberman died, but I'm assuming it could be something related to that.
What happens with age, and this is not uniform, this is not 100%. So majority of the time as we age, our brain substance decreases. Yes, we're smarter, we are more experienced, but the amount of brain that we have, the amount of it decreases, but you still have the same skull size. So if you look at a scan of somebody in their 80s, their brain looks like it's actually smaller amount of brain, which makes the space between the brain and the skull even more. There are veins that go between that space, between the skull and the brain. So now a young person, the brain is stuck within the skull, an injury, it's not going to damage those vessels because there's not much shifting in the brain inside the skull. Somebody has a smaller sized brain and a skull that's the same size, the brain shakes a little bit, it tears one of those vessels and those vessels bleed. So that's why minor head injuries in the elderly population usually results in some sort of bleeding and brain injury. Age is a factor.
Yeah.
Age is a factor. So if you're a child, children and adolescents, they can have the most severe, head injury and still make a full recovery. And they can be almost brain dead and come back and have full recovery. Elderly patients, you can tell the bigger the injury, it's very hard for them to come back from that because the brain has less recovery ability over time.
Most of the time, the recovery from what we see with the minor trauma, they really don't need much intervention at all after the injury. It resolves on its own and they're fine. It really depends on the amount of brain tissue that's been injured.
I mean, globally in neurosurgery, where we are today versus 10 years ago versus 5 years ago, it's not a day. I mean, we're talking about robotic surgeries now, robotic neurosurgery, which is both spine and brain. That was unheard of before. Navigation, I remember when I trained, and I don't want to sound like I'm too old, I started way young, so I've been at this for a long time. We were supposed to know how to get to places without any imaging modalities to show us exactly where we're going. So based on symptoms and based on presentation, we're supposed to know, hey, I think there's something in this area. Go in there and look in that area and see what's going on. And then, of course, now you had MRI scans, CAT scans, and then you have now navigation tools where actually with a pointer, I can point at somebody's head in the operating room and know exactly where I am on a big screen in 3D, right? So that's what we have now. And then robotics is basically the robot is doing the surgery while you're in the control room. And the robot that I'm interested in, which is going to come out in the next 2 or 3 years, which we're going to be in the front end of it, because it's going to be a brand new technology, is going to be able to do the entire operation while I'm sitting on a console playing like a video game almost, and not ever have to put on gloves, to actually do the surgery. So, for example, our brain tumors are less than 24-hour stays in the hospital. They're basically outpatient surgeries. So we take out brain tumors through small openings, and the patients go home from the ICU within less than 24 hours after surgery. Majority of my spine surgeries are done through small incisions, and I would say 80% of them are outpatient surgeries. Mm-hmm. You don't require admissions. And then I'm talking about neck and back. So, currently the technology that we have is dramatic from where we were 5-10 years ago.